We usually held on first of Wednesday every month, and it has been going since last 40 years. I will give you an introduction, sir. Dr. Sushil Parulkar, he has done NCH Ortho, Liverpool in UK. He is a founder member of International OTA. He is a member of Online Discussion Forum Committee OTA. He is president of Trauma Society of India. He is a board member of Gerhard Kunstler Society, and he is the chief operating surgeon in Center of Joint and Joint Reconstruction Surgeries, Institute of Medical Sciences, Nagpur. We welcome you to Solapur, sir. You can share your screen, sir. Now.
मी दिसणार नाही रे फोटोमध्ये आम्ही त्याच्यासाठी आता तोड केलेलं आहे. तू तिकडे गेला. नाही त्यांनी बघायचं बघून टाकलं.
Are you able to see the screen?
No, not yet. Not yet.
No.
No. Sir is going to deliver a lecture on junctional fractures in long bones.
Yeah, yes, we can see her.
You can see the screen now?
No, sir. Just allow me, sir.
Yeah, it's a meeting there.
Yes.
Now it's visible, sir.
Now it's visible?
Yes, sir.
Okay, so thank you very much for inviting me, Solapur. And this is the first case which I am showing. This is lower end of femur fracture. Obviously, we all want to treat this by surgical means. And the commonest, let this be interactive. So you can stop me and you can ask me questions and we can talk about it.
Okay, sir.
So, is everyone agreeing to this construct?
Medial
Sir, Dr. Milimoki, in my opinion, I'm not happy with the proximal fixation. The locking screw should have been much nearer the fracture site, and the particular screw across the fracture site, we don't know whether it has been passed with the interfragmentary mode, and if it has been passed in an interfragmentary fashion, the direction is wrong. So I am not happy with this construct.
Okay. So, any other thoughts on this by anyone else?
Dr. Sophie here. So basically, this is a mixed up of principle with the absolute stability and relative stability. So it's an interfragmentary with long screws, long plate in the proximal side.
Yes. So when we all started doing these locking plates,
and one more concern most of the times is about the medial buttress. So if you see a bit, which time probably it may go into varus and there may be an implant failure. So some medial buttress is required usually in such cases.
Agreed. So agreed to all the three comments. When we went through the whole cycle of using locked plates for this fracture, some of us, we did put this interfragmentary screw to bring in closer the fragment, which was maybe a little tilted and maybe a little displaced. So we used that. And now as the time has progressed, we realize that that screw is going to mix the principles of absolute stability and relative stability. Though absolute stability is a known terminology for comminuted junctional fractures, for such single line junctional fractures, absolute stability is not required. So you want a relative stability for such fractures. and we do not want an absolute stability till it is a established non-union. So that screw, this screw which Milind was talking about, should have been removed after achieving good reduction. So in such cases, of course, those 10-15% of the patients would need some additional medial support as well. Let's see what happened. That's 2 months down the line. It is not healing good. And that's how he presented with. He presented with a broken implant. He presented with non-union. He presented with varus failure. And we again, all of us, we went through all this cycle of not adequately fixing lower end of femur, 15 to 25% failing into varus, and thus the topic of whether some of these fractures would need a medial support came into vogue. So what we did was we just put in a nail and we supported that with a new lateral plate. Some bone grafts were added, and look what happens. Very soon it starts throwing medial callus, and it forms a solid callus within 6 months. So here the intramedullary nail has acted as a medial buttress with this lateral plate which was used for fixation. So should this be done primarily to have this amount of callus formation? So I think it is a good idea to add medial buttress to a lateral plate, um, and add stability to this junctional lower end of femur fractures. So here this junctional fracture in question is lower end of femur fracture, and the medial buttress here or another additional support here is the use of intramedullary nail. Now, should the nail be longer or plate be longer? Or should we use nail plus plate or plate and plate is another question for another day. Let's look at this fracture. Again, a comminuted lower end femur, comminuted lower third femur, a segmental fracture. Here, what I chose was, of course, an intramedullary nail, retrograde, and only a small buttress plate. Here, the whole purpose of showing this particular case is I have chosen this plate in a composite fashion. So you pass the retrograde nail as such. And then with the jig on, with the jig in position, you can actually put a plate on the lateral side and some of the screws. Now there is a plate also available wherein you can put 2 to 3 screws from the plate through the nail in various directions. So it's going to give you an ability to do a multi-planar, multi-angular composite nail plate fixation. Why do we need to combine a plate and a nail? Because then the whole construct, whenever it's required, especially in comminuted junctional fractures, will add 30% more biomechanical strength. So here we are by design choosing absolute stability. So now relative stability for a linear fracture, single plane fracture, to absolute stability in non-unions, to absolute stability in junctional comminuted fractures requiring an additional second fixation, either a plate or a nail plate is what the whole world is talking about. So another example, Givet nail plate, which was done 45-50 years back. We don't see this these days, and a fracture at the tip of the existing Jewett nail plate. Now I had a tough time, of course, removing this Jewett nail plate, but what I chose here was a retrograde nail, removed some of the screws of Jewett nail plate and put a lateral plate. So this is what I chose. And if you can see, very early on, it started throwing callus. I use now a nail and plate. Even for junctional fractures here, it's a proximal forearm, a ulna. Here I have used the same for, so let me just go back here. So even in forearm fractures, comminuted, unstable, segmental in case of ulna, I used a plate and a screw in nail, which gives a combination of absolute stability again. Another example is this lower third humerus comminuted fracture. Fantastic for anterior plating passed percutaneously. But you pass a retrograde nail, sorry, antegrade nail and a percutaneous anterior plating will give you a fantastic nail plate combination for this unstable lower third, especially if there is a comminution. And it will throw a great amount of callus because everything is done mostly in a closed way. You don't have to worry about this butterfly fragment or closing the butterfly fragment. Another quick example is this very interesting bifocal fracture, wherein there is one component which is intercapsular or trochanteric, another component is subtrochanteric. To a nail, pass a hook plate, which will give you a combination of nail and plate. But when you pass hook plate, you have to make sure that one of the hooks is embedded in the nail so that it's a composite complex again, nail and a plate. And I love putting that transverse cancellous screw, which goes like a Powell screw, pushing the hook together, closing the trochanter, and if there is any lateral wall fracture, even that is taken care of by this composite complex nail and plate. Here I have also used a cerclage wire done in a biological way. So this particular example is a combination of nail, hook plate and cerclage wiring together for this unstable trochanteric fracture, which had a lateral wall fracture, which had a posterior medial wall component. And then these patients give you a good night's sleep because the whole thing is going to be very, very stable. Someone who was a big fan of mine, rheumatoid patient. I had done his total hip few years back. He sustained this fracture. Same time, both femur were fractured. He was waiting for his total knee replacement to be done. Again, for such grossly osteoporotic, though young, grossly osteoporotic fragility fractures, choosing an implant is a tough task. What I chose here was doing a retrograde nailing on both the sides and using a long lateral plate to fix across the fracture. Here I tend to choose a long plate and if possible have some purchase also in the trochanter if need be. But this was good and he was mobilized immediately. Now he is waiting in a few weeks to undergo his total knee replacement once the fracture gets healed because I will need an intra-articular jig for a better total knee alignment. That's my choice. One can do with extra articular jigs also, total knee replacement. I prefer to do and use an intra-articular jig, so I'm just waiting for good bony union. So again, for this junctional fracture, primarily done nail and plate combination will give you a better absolute stability and take away the need of putting a medial buttress plate when it is precarious, especially on the right side. If you see that zone is crossing where we are bothered about the vessel going from anterior to posterior compartment. So that was a precarious junction fracture. So I chose to do a nail and plate combination on the right side. So similarly, because I wanted a symmetrical combination of implants used, technique used, I chose even for the left side, same technique of nail and plate combination. Lower end femur fractures is a different ball game altogether. We all have written about it. So on the left side, the first slide is of course use of Andersnell, which Sunil uses for creating a medial buttress. People have used double plate. So what's the difference between biomechanical strength of double plate versus nail and plate? Both are biomechanically equally strong. Surgically, medial buttress plate more difficult because even the anatomical medial femoral plate that has been designed is not giving enough stability if there is comminution present at the Hoffa's level. So if there is a medial Hoffa's component, then this plate doesn't purchase all the comminuted Hoffa's fragment. So double plate doesn't work in those cases. That's the downfall of both the plates for lower end femur fractures. Using a web cage or spinal cage, very good idea for filling the defect on the medial side. Of course, if there is a lot of comminution, and we have written it up for more than 80 cases now, comminuted, junctional, lower end of femur fractures, osteoporotic or even young, nail and plate combination probably is better. Now, if you see in this case, he had comminuted Hoffa's on the lateral side. So I had to fix the lateral Hoffa's, fix it with a plate, and use a retrograde nail for supplementing as medial buttress for taking away the need of plate, again because here also the length of medial comminution was extending into that vascular critical zone on the medial side. How far should be the plate? Should the nail be longer or the plate be longer? If it's an osteoporotic bone, the plate should be longer and it should have a screw which will probably avoid fracture intracapsular, which might be at the crucial juncture of developing a periprosthetic fracture. And if you see, this is the same patient. As early as 6 months, he started throwing callus on the medial side. It's rock solid. It is a very convincing way of fixation for such comminuted closed fractures. Though comminuted, you preserve the biology on the medial side. All the combination will throw a huge amount of callus and you don't have to worry about it. If there is an intra-articular comminution, you reconstruct that well. Once it is reconstructed, then we have all done through intra-articular comminution nailing. We are all geared for that. Here, because of the junctional fracture comminution, throw in on day one additional plate. You will avoid failure. The only caveat is in some cases, you have to probably wait for a longer time. This kind of absolute stability as against relative stability takes 2 to 3 months longer for throwing callus, showing radiological callus, but keep patience, it's not going to fail. It just takes time in cases of no or minimal comminution. If the comminution is high, in 4 to 6 months, you'll be able to see radiological callus and your mind will be at peace. Another example, failure in varus, comminution on medial side, replace that with a retrograde nail, longer plate, you'll be okay. But there are some fractures which are lower fourth, absolutely parallel to the articular surface, wherein there is no way your nail will have purchase with the screws. Here is one indication.
One minute.
Now these fractures you will also tend to see with a lot of
So,
TKR patients,
hello.
wherein we still have
He's
to
not
use
listening.
double plating
Okay. Only
to
one. So,
make sure that you reconstruct the geometry and you support this collapse and comminution with double plating of unequal lengths, because medially you can't go as high as lateral plating. So I think that's one
Hello.
indication in my mind wherein you have to still use double plating. Another indication, if
Sir.
the TKR
Hello.
femoral component is having a box, a fantastically passed retrograde nail, a longer plate with a screw going across the subcapital area is always a good idea. But still, if the fragment, the bony fragment attached to femoral component is too tiny, very less bone, double plating will still win over nail and plate combination. So I think super combination, while lateral lock plating is limited by off-axis loading, intramedullary nails can be too flexible sometimes, resulting in failures when used in isolation. So here, nail plate construct provides a better biomechanical advantage of both the implants with improved axial and torsal stiffness. I think the amalgamation of nail and plate offers a dual benefit. It will not only allow potential axis loading, these patients can start weight bearing early due to the presence of the nail, but also enhance the torsional resistance through the plate. So torsional resistance achieved by plate and axial stiffness that's required by the nail. Me and Tanna sir, we have written about our initial thought process of nail and plate in this, and I have also published in Indian Journal this article on delayed union and non-unions in junctional fractures, and one can refer to that and read it. It's August 25 journal. The thought process is, though initially it may appear to be an overkill, and as Tanna sir always say, overkill probably is better than dealing with non-union or delayed union or failure of implants. Integrative approach on day one, combining mechanical and biological optimization, form the cornerstone, especially for these junctional fractures, especially when junctional fractures are comminuted. So there is a paradigm shift towards early robust fixation with adjunctive biological advancement. Now, one can take a call if you are extremely scared or very finicky, or you don't want to do do too many implants. One can wait for 3 to 4 weeks, and at that point in time, once the fracture site quiescens down, you can add a lateral plate to your initial uh, retrograde nailing. But lateral plate has to go always later than retrograde nailing. That's number one. Number two, then you also lose chance of creating a composite nail plate combination, which means passing 2 or 3 screws through the distal locking hole of the retrograde nail, because that's going to add to 25-30% of more biomechanical strength if it's a composite nail and plate combination. Thank you very much.
Thank you. Sushil, can you hear us? No, I think it's muted. Phone करो सका.
Hello.
Hello.
Sorry?
Hello. Sushil,
Oh,
can you hear us?
yes, I can hear you. I can hear
Okay,
you.
because we wanted to
Oh, Swapnil, I
disturb
can
you
hear
in
you.
between few times, but you couldn't hear us, that's why.
No, I could not hear you. No,
Yes,
sorry.
that's all.
Sir, just a small, I had one query. In one of the cases where you have used a nail and plate combination, I saw that you could bend the plate when it was reaching the trochanter.
Yes.
So how did you bend that?
So that was a steel plate. Titanium plates are impossible to bend.
Uh,
I almost always use a steel plate if I am required to bend it. And you always need to bend it to fit the trochanteric flare. If you want to ride above the trochanteric flare, you always need to create an S bend.
But with which bender is press?
एवोचा मोठा प्लेट बेंडर
Okay,
जो आहे
okay,
एवोचा जो
okay.
मोठा प्लेट.
Okay.
Yeah.
Sir, Swapnil.
And my
Uh,
assistant is bigger than you, Milin. He is taller and more robust than you.
Sir, one more question. You have shown one
Yes.
severe RA case with THR on one side and there is a suprapular fracture distally on bilateral femur. So, do you feel any
Yes.
difficulty in putting a IMSC in severe ONA due to flexion fractures or difficulty in doing flexion? Entry
Go
point.
again, Swapnil. I didn't understand the question.
Okay, so
In that
there is a
particular
severe RA.
with,
Severe bilateral RA case with suprapular fracture with bilateral total
Yes.
replacement. So on the X-ray, it seems that there is no range of movement in the knee. So how you tackle in these type of cases to enter the
even,
nail?
even if the knee can flex up to 30-35 degrees, you can
Okay.
pass the retrograde nail. Don't worry.
Okay.
So 30-35 is the minimum that's required. With
Okay.
zero amount of flexion, you cannot pass retrograde nail.
Okay.
So the
And-
minimum amount of flexion that's required for retrograde nail passing is
Okay.
30 to 35 degrees.
Okay.
Yeah.
And one more question, what is your routine approach when you are making a nail plate combo? Approach while you are making a nail plate combo.
So if there is a comminuted intra-articular lower end of femur, swashbuckler.
Okay.
If there is um, an intact lower end of femur and junctional level, it is comminuted, then a separate incision paramedial for retrograde nail and a separate lateral incision as we do for lateral plating as usual.
Okay, so it's
Two
like
separate
taco.
incisions.
Okay, okay, yes.
Got it.
Any question? एक मिनट प्रदीप सर want to ask something. Krishna, good evening here. Pradeep Kothari here. Yeah.
हो सर बोला ना.
Yeah, this is regarding your nail plate combination for irrigation. Is it really that necessary to have? Because for junctional in lower limbs we can understand. For irrigation, instead of doing a nail plate combination, can you add one more nail, stack nail, to fill the medullary canal and get a good stability?
So
Or
in
is
that
it-
particular case, I had fracture which was primarily olecranon fracture on the ulna side and a mid shaft ulna. So I wanted to use a plate, but because the shaft of ulna was comminuted, I thought of using a plate to fix the ulna, fix the olecranon, extend it till the shaft and put a nail also. But yes, if it's a segmental two-level ulna mid shaft fracture, maybe stacking of nail is a better idea. Yes, I agree.
Thank you. In cases when there is a total hip with a fracture at the junction lower in the femur, you are shown in one of the case to use a retrograde and a plate. What size of retrograde nail you have? Because I think last week I was trying, I was not able to pass 25 centimeter retrograde nail because the nail was protruding out of the in the knee. So what size of the nail you are having in it? Or in short stature?
That's too
Do
technical.
you have a custom made nail in short stages?
No. These are all regularly available nails by Nebula. I can take the name. So Nebula provides those short nails also are there with Nebula.
They were short
And in
nails.
fact, Nebula has come with composite nail and plate combination also now.
Okay, okay.
Because the owner is an orthopedic surgeon, so he understands our psych.
Okay. Then I wanted to ask about the size of the retrograde nail. How much length?
Oh, I understand.
Yeah.
So shorter retrograde nails are available, sir.
With whom? I was not able to get. Nebula. Thank you. Excellent.
Hello, sir. I am Dr. Adarsh Mehta. I just want to ask, what are the tips you can tell us if there is a periprosthetic fracture after doing total knee and while passing the retrograde nail? In case of that, do you think any difficulties to do that retrograde nailing in case of when there is a less need particular?
Yeah, very good question. So number one, we need to go back to what processes was used and see if that processes box has an ability. Some boxes are closed, then we cannot pass retrograde nail. And if we are planned only for using retrograde nail, then we get stuck. So it is important to know what implant was used. Number one, there is a lot of misconception in the mind of our colleagues that a broader retrograde nail cannot be passed through the box. The box is always 14 millimeter. So there is no problem of passing 14 millimeter retrograde nail through that box. So don't worry about it. Number three, once you pass the retrograde nail through the box, as it will cross the isthmus, the lower end of femur will automatically get adjusted to the anatomical axis that has to be followed, except when if there is a total hip up there, then you are in trouble. But if there is no total hip stem stopping your retrograde nail length, then you pass the retrograde nail as long as possible. So the entire total knee femoral component will get adjusted to the desired anatomical position. Once that is done, you put a plate laterally as long as possible. Most of these total knee, total hip, periprosthetic fracture patients will be osteoporotic. So we have to cover the entire length of the bone. So you pass the proximal screw in the neck to avoid, because I have seen so many patients coming back to me after putting a shorter nail and a shorter plate with tip of the implant proximal fractures. So that's very important to pass the oblique screw in the femoral neck.
थोडा इथे दाखवा मला त्याने बघू दे मी साईडला बसलेला आहे त्यामुळे येस you should
Ah, Shiva, hi.
presentation
Krishna
as
Prabhu.
well, especially that process is in both the side deep, but severe osteoporosis and the fracture you have managed so beautifully. I was really impressed by that case. Though other cases were also equally good, but in this one really to get a case of bilateral nailing with the augmentation plate with the hip replaced, it's really a wonderful thing. You should present that case somewhere. Yeah. Congratulations, and on behalf of Solapur Orthopedic Association Society, I take this opportunity to thank you. I'll hand over the mic to the president.
Thank you, Shiva.
Sir, thank you for giving us the time in your complete busy schedule. At least 20 minutes, we are very happy. Thanks a lot.
No, no, no. Thank you very much, Swapnil. Actually, I have a wedding in the family. So I finished the pleasure and honor. Thank you.
Yes, sir. Thanks a lot. To me, no, yes. Thank you, sir. Thanks a lot. Thanks a lot again. Yes, thank you.
Bye.